I'm Josh Young. I'm here with John Kanellopoulos. We're going to be talking about collagen cross-linking, and I want to start out asking you, in the context of your own practice, who are the bulk of your cross-linking patients?
And, it actually so turns out that over the last 15 years, collagen cross-linking is almost 50% of my cornea practice. As a cornea surgeon, I always dealt with keratoconus patients. Currently in Southern Europe, I see anywhere from 40 to 50 young keratoconic patients a week. So with this astounding number of endemic presentation of keratoconus, we end up managing the progression with our combined technique, normalization with topography-guided laser, and higher fluence collagen cross-linking. So it's anywhere from 5 to 10 cases a week that we perform from mainly Greek patients, but we see patients from all over the world.
John, what is high fluence collagen cross-linking, and how does it differ from standard collagen cross-linking?
We introduced the concept of higher fluence collagen cross-linking in an attempt to be able to cross-link a cornea that we had placed a single amount of riboflavin through a femtosecond laser pocket. This is almost 10 years ago, and in that process we automatically turned into the standard cross-linking procedure and applied higher fluence anywhere from, instead of 3 milliwatts, which is the standard Dresden or Zurich protocol, to 6, 10, 15, 30, and currently 45, believe it or not, milliwatts per centimeter square. Now, the advantages of using higher fluence is obviously you shorten significantly the amount of time needed for the procedure because the actual energy delivered to the cornea is the same. Some of the potential disadvantages where if there's potential oxygen there to drive the procedure. We have conclusive data from our studies, and we've published on this, that it actually works at least the same, and there's a potential advantage of using higher fluence being less destructive to cornea keratocytes, as fibrocytes in nature in general are more resistant to higher fluence for a short amount of time against lower fluence exposed for a longer amount of time.
Having said that, John, are the indications for high fluence different from standard fluence? And given the advantages that you mentioned, are you even doing standard fluence anymore, or are all of your patients now high fluence patients?
I thank you for asking this question because I think it's key to what we practice in our center currently. We do not use standard fluence collagen cross-linking, with the only exception for treating infectious keratitis. There we want to have very long exposure times with lower fluence to potentially then become bacterial and fungicidal. Now, as far as the higher fluence, we use 6 milliwatts for our standard Athens protocol technique, which is the very frugal topography-guided normalization and collagen cross-linking. So it's 6 milliwatts for 15 minutes. And then we use 30 milliwatts for our LASIK extra technique, in which at the conclusion of a LASIK procedure, we reinforce the cornea through the repositioned flap, and after we have placed a small amount of riboflavin within the exposed stromal bed. And we have proven, actually in last year's meeting, this got the best residence paper, that in application of this in hyperopia, we have a very significant stabilization of the hyperopic correction 3 years to come. Regression in hyperopia over 2 years in hyperopic LASIK has been a big problem internationally.
John, this is really neat stuff. It was a really good talk, and I'm just really happy to have you here today.
Josh, thank you so much for the opportunity.